Good morning, everyone. I hope you can all hear me. It has just turned 11 a.m. Eastern Standard Time, so we are going to go ahead and get started today. Good morning. My name is Deirdre McGinley-Geyser, and I am the Senior Vice President of Programs here at AICR. It's my really great pleasure on behalf of everyone at AICR to welcome you to this Lifestyle and Cancer Symposium. The selection of our theme today, Evidence Matters, we think is particularly timely in today's current environment, and even more so in the fields that you all work in, addressing health and cancer risk through nutrition, diet, physical activity, and weight. So we're looking forward to some lively discussion. I'd like to thank our co-chairs for the symposium, Dr. Catherine Schmitz and Dr. Eric Nelson, who are pictured here, and who have created a dynamic and engaging program for you today. For those of you who may not be familiar with the American Institute for Cancer Research, or AICR, let me take just a couple of minutes to share our mission. Together with our sister organization, the World Cancer Research Fund in the UK, we're known as the world's leading authority on the links between diet, weight, physical activity, and cancer prevention and cancer survival. And this is largely due to our expert reports, the first of which was published way back in 1997, seems like a generation ago now, and the latest, the third, in May 2018. And it's from these reports that both AICR and WCRF derive our cancer prevention recommendations. So research is certainly our foundation and core work, but AICR is so much more. We provide awareness, education, and advocacy to help all Americans take real steps to reduce their cancer risk. And you will find a wealth of information and tools on our website to help individuals and communities as we work to reduce the 40% of cancers that we know are preventable in the US. As I mentioned, the chairs and program committee have developed a great schedule for today. And we have an incredible lineup of speakers for you to hear. I'd like to thank the co-chairs and the program committee again for all their work, and also now thank the speakers who have made their time to prepare and present and be with us today. You see them all pictured here, along with other program committee members, and you'll meet them during the course of the day. I'd also like to thank our generous sponsor for this symposium, California Walnut Commission. California Walnut Commission are a great partner of AICR. We've worked together for a long time and we just love our partnership with them. We're very grateful for their support for this event. And finally, just before we start, I want to go over a small bit of housekeeping to do with navigating the symposium online. Each session, as you've probably discovered by logging on, takes place in a different Zoom room. So you actually have to virtually move rooms to get to the next session. So this is how it works, and you can see the screenshots on this slide. 5 minutes prior to the start of each session, a blue Join Session button will appear next to the session title on the virtual attendee hub. Once you click this, you'll be brought into the second room. Then you need to click the Join Session once more, and you're placed into the virtual session. So that's 2 clicks you need to do. As I said, each session will take place in its own separate room. So at the end of each session, you will need to navigate back to the Virtual Attendees Hub main page using your browser back button and click the Join Now button for the following session. So you won't be automatically placed into the next session. You need to follow those steps to actually get there. I hope that's clear. There's a Q&A section on your virtual hub if you have any questions. But I think as long as you click the blue buttons, you should be good. If you have questions for the speakers, you can input them into the Q&A box on the right-hand side of each session room, and these questions will be addressed at the end of every session, as well as at the very end of the event in our panel discussion. And finally, I certainly can't leave without doing a quick plug for our annual research conference in November of this year. We are planning for an in-person event. Of course, we will pivot quickly if it becomes obvious that we can't do that, but we're keeping all our fingers and toes crossed. And I really hope that today's sessions whet your appetite for more of these kinds of discussions, and you'll consider joining us in November. We will have the luxury of more time then to really dig into some of these issues and many, many more. So now I promise to the main event. It's my absolute pleasure to hand over now to Dr. Catherine Schmitz, who is chairing the first session, and I believe is all ready to get going. So Katie, over to you.
Fantastic. Thank you so very much, Deirdre. And so delighted to be with you all today, and really, really delighted to get to make two introductions of leaders in the field. This first session, called Strength of Evidence, really forms the background and backdrop for the rest of what we'll do today. So it is my absolute pleasure to introduce to you all Dr. Kostas Tsilidis. I'm going to hope that that was close on the name, who is a senior lecturer in cancer epidemiology in the Department of Epidemiology and Biostatistics at Imperial College London. Since a year ago, January 2020, he has become the co-PI of the World Cancer Research Fund Continuous Update Project at Imperial College, which, as you all know, performs evidence synthesis of diet, adiposity, and physical activity associations with risk of cancer development survival. And he is a molecular epidemiologist with a strong focus on cancer etiology and prevention. His research focuses on genetic, dietary, metabolic, and hormonal pathways in cancer development, prognosis, and survival. I hope you'll join me in welcoming Dr. Tsilidis.
Thanks so much, Katie, for the introduction, and for AICR for inviting me to present. So I'm gonna present you in the next 15 or 20 minutes the Continuous Update Project, the AICR WCRF Continuous Update Project. And I'm jumping right in. So this project is one of the most rigorous, systematic, and ongoing programs of work that gathers, presents, analyzes, and judges the evidence linking diet, adiposity, physical activity in relation to cancer risk and cancer survival. So as Deirdre said a few minutes ago, this whole process started in 1997 with the first expert report, and it continued in 2007 with a second expert report. And then in 2018, we had the third expert report. But the Continuous Update Project basically started between the end of the second expert report and the start of the third expert report. So during this approximately 10 years or more, we have been continuously collecting and analyzing the literature data for the association of diet, adiposity, and physical activity with cancer. So our team at Imperial College London collates the worldwide evidence continuously in a central database located at Imperial College. So we prepare protocols, conduct systematic reviews and meta-analysis, and prepare reports that are then shared with external peer reviewers, and then with a panel of scientists, experts that are collaborating with AICR and WCRF in order to evaluate the reports and the associations and draw conclusions and judge the quality of the evidence, and then and suggest recommendations. And then the AICR WCRF uses these recommendations and these panel conclusions to make the final recommendations to the public and set research priorities. So there are a large number of individuals and scientists involved in the WCRF AICR CAP. So everything starts at Imperial, where, as I told you before, we collate all the literature evidence, do systematic literature reviews and meta-analysis, also in collaboration with the WCRF and AICR Secretariat, which provide and help us in also to some extent in the day-to-day management. We have experts who peer review our reports, and then the CAP panel reviews our reports and makes recommendations. And we also have input from researchers from IARC, from the International Agency on Research on Cancer in Lyon in France, where they provide their expertise in assessing mechanistic evidence, which we also use in judging the quality of the evidence between diet, adipose, physical activity, and cancer. So in a nutshell, we collate the global research on diet, nutrition, physical activity, and cancer, both cancer risk and cancer survival. And we analyze the evidence and extract the evidence to our database and analyze it. And then the evidence is judged using predetermined grading criteria by the expert panel of WCRF AICR, and then the evidence is presented in reports. So this is another way of presenting kind of the process of the CAP. So I need to kind of make sure to focus that the whole process is very systematic. So have a lot of different procedures to make sure that we have the highest possible internal quality control and also external quality control. We have specific guidelines and protocols that we have to follow, and they're always peer reviewed by external peer reviews, but also by the CAP panel. We have specific procedures to standardize our procedures and double checks, and also we have peer reviewers in the CAP panel that double check our data and our results. So during the last 10 years that the CAP has been going on, it has published 19 different reports, systematic literature review reports. So 17 of them were on the association of diet, adipose, physical activity, and risk of separate cancers, development of separate cancers, 17 separate cancers and their subtypes. And also one report has been published for the association of the same exposures to outcomes after breast cancer diagnosis. That was published a few years back. And then one report is also published for determinants, evaluating the evidence for determinants of adiposity and weight gain as outcomes. And you can find these reports in this website, dietandcancerreport.org. So I want to talk briefly about how we reach the level of evidence at the end of our approach. So the quality of the evidence is judged using some, as I told you before, predetermined grading criteria. And we are reaching either strong evidence or limited evidence, either for a decreased risk, an increased risk, or no risk. Or a null association. And further from these two initial ways to categorize the evidence to strong and limited, we have some further subgroups into convincing and very likely causal effect. And the same now with limited suggestive and limited no conclusion among the limited evidence. So the criteria we use to judge the quality of the evidence, first of all, I have to mention that this is a process that is intrinsically subjective, and it's an expert panel decision based on the evidence that is shown to them. And but the different criteria we use in order to help the panel reach their final evidence gradings are the design, the study design, and number of available studies, the quality of the exposure and the outcome assessment, the exclusion of chance, bias, and confounding, between study heterogeneity. We assess between study heterogeneity in our systematic reviews and meta-analysis. We also assess the presence or absence of a biological gradient or dose response in the evaluated associations. And we also check whether there is evidence of mechanisms supporting the epidemiological findings, and the size of the effect plays also some role into the final decision. I will open a small parenthesis here in saying that several different organizations and researchers are using their own sometimes different set of criteria to evaluate quality of evidence. There are a large number of options if a researcher wants to evaluate quality of evidence. And there are differences in the terminology of the different tiers, categories of how the evidence is evaluated, but also a few differences on which criteria different organizations might use to judge the quality of the evidence. However, to a large extent, we are seeing similar gradings of the evidence at the end. So just for a small example here, this is the evaluations of the quality of the evidence in the association of obesity in relation to cancer risk by cancer type, that are supported by convincing evidence in different organizations or researchers. So this is the WCRF AICR report for different cancers. And one is, the green tick means that this is convincing evidence. Otherwise, it's mentioned in words. And then a similar but independent process was done by IARC almost concurrently with the WCRF reports, and it was published in a paper at the New England Journal in 2016. And this is another approach that this is part of my research team work, where we don't have exactly an expert panel to decide the quality of the evidence, but we use, in quotes, more objective criteria, so sensitivity analysis and some extra statistical measures in order to help us decide the quality of the evidence. So despite all these things these approaches are quite different in the criteria they use, the conclusion of the quality of the evidence is quite similar, with few exceptions. So overall, the conclusions in the convincing category in the AICR WCRF approach process, so it means that we have a strong association, which is unlikely to change in the future. We have no unexplained heterogeneity between study heterogeneity, and we have at least 2 independent cohorts in the relevant meta-analysis. Most often we have more than that, but it's at least 2. We have good quality studies that account for error, both systematic and random error. And we have very likely dose-response association and robust supporting evidence for a clear mechanism from laboratory studies. So overall, I'm showing here the findings, the overall summary of conclusions from our 3rd expert report in 2018. So you can see the different cancers, approximately 20 different cancers of the subtypes on the y-axis on the left-hand side, and then on the columns you will see the different dietary variables, adiposity and physical activity towards this end here. And the different colors mean the different levels of the quality of the evidence. So the red means convincing evidence for increased risk, and then the green means convincing evidence for decreased risk. So if I have to summarize the evidence in a couple of sentences here, we are seeing that adiposity and alcohol consumption are the 2 strongest contributors to cancer development, as you can see here for alcohol and here for adiposity. In addition to that, we have a number of cancers that have been convincingly associated with a decreased risk in relation to physical activity, like colorectal cancer, postmenopausal breast cancer, and endometrial cancer. And then we have a fewer number of cancers that have been convincingly associated with certain single dietary factors, and most of them are actually for colorectal cancer. So we know that dairy products, calcium, and fiber are inversely associated, and whole grains are inversely associated with colorectal cancer, and also that processed meat is positively associated convincingly with colorectal cancer. However, what we have been doing in the last couple of years is preparing for, let's say, the next phase, the next wave of research in nutritional epidemiology. So as we all know, the research that the vast majority of the research that we have currently assessed in our 3rd expert report is nutritional epidemiology studies that have relied to a large extent on a single assessment of diet, using most often food frequency questionnaires. So this approach is definitely prone to measurement error for several different reasons. One of them is that, especially for intake of non-habitually consumed foods, there is a large likelihood of not accurately measuring the intake of those foods using food frequency questionnaires due to poor recall to some extent. And also the intake of certain dietary factors like vitamins, minerals, or fiber has an extra source of error. Not only we have to capture how many times we episodically consume the different foods that contain those dietary factors, but we also have to take into account that we use nutrient databases in order to translate the nutrient content of a certain food. So we have an extra source of error from these nutrient databases. And in addition, in many of our epidemiological studies, apart from the error we have in the measurement in the diet component, in the dietary variable that we use as our exposure, that most often this error, at least in prospective cohort studies, is non-differential. So it's not associated with the outcome. And it leads to a loss of power and also and I think a bias towards the null association. However, if in the statistical models we build, we also include, and very often we do, other risk factors to act as confounders, and many times these confounders are also other dietary factors apart from the dietary factor we assess as the exposure, then the measurement error in on the confounder may actually lead the overall bias of the model to any direction, either to the null or also to higher risk estimates. So an even worse, regardless if we're using a prospective cohort study or not. So there are many sources of error which nutritional epidemiologists know very well and try as much as possible to deal with. As I told you earlier, in the CAP, we're trying to prepare for a new wave of studies that will measure diet in potentially a better way in the near future. So some of the methods that have been proposed and some of them have started to be used are to use repeated diet records or other questionnaires, and using sometimes a web-based approach so that it allows for those for questionnaires to be given to be filled in many times in regular circumstances by our participants in our studies, but also a new method of participants taking photographs of their foods and then using image recognition software to try to understand the type of food and also the amount consumed. It's another way that may gain some prominence in the future. It's still in its infancy at the moment. And also evolving and ameliorating biomarkers of nutritional status is another method that is likely going to gain prominence in the future. And we also have a couple of studies that using omics technologies, for example, metabolomics, we can use biomarkers of metabolomics to approximate intakes, certain patterns of dietary intakes. So I'm opening again a small parenthesis just to show you some of my actual research outside of the CAP before I joined the CAP, but also it's continuing nowadays. So we actually took the evidence from the WCRF AICR CAP on the association of diet and risk of cancer at 11 anatomical sites. And we wanted to get an idea whether or not further research on top of what we already have after the third expert report in diet and cancer may provide a meaningful contribution to the existing evidence. So we used some already available and developed research metrics that are most often used in the RCT world, like the fail-safe number and the conditional power, to try to estimate whether additional research in this field could provide a meaningful contribution. So the fail-safe number, basically, it applies to the statistical significant meta-analysis it estimates the number of future studies of average null effect and average weight that are needed to detect a non-statistically significant summary estimate. So to drive a statistically significant meta-analysis to not statistically significant. So how many new future studies of null effect we will need to drive a statistically significant meta-analysis to a null meta-analysis. And also the second metric is kind of the vice versa approach, where it's called conditional power, and it applies to the non-statistically significant meta-analysis and estimates how many future studies are required to achieve a conditional power of at least 80% to detect a statistically significant effect size. So I'm not going to show you too many details of the actual results, but in conclusion, we found that additional similar research, and I'm kind of bolding the similar research, I think it's very important, is unlikely to change the current evidence for the majority of the associations that we have evaluated and we used from the previous, from the third expert report, with only a few exceptions that pertain mostly to currently observed null associations between single dietary factors and a few understudied malignancies. So the reason why I want to highlight this similar research is because it's basically using the kind of approach that I mentioned before, so that most of the studies have assessed nutrition at one point in time using mostly food frequency questionnaires. But we hope that in the future this can change and we can have a new wave of studies that potentially assesses nutrition in a better way and a new wave of evidence. And this is actually the reason why in the last couple of years, the CAP has created a transition panel to discuss ways and options to improve, to check and improve our current approaches, and also to suggest areas of future research and of future focus of the CAP. And I will come back to this towards the end of my talk. So going back to the CAP, this is another approach or another illustration of how the evidence produced by the CAP is basically shown to the public in a more palatable way of how different associations between diet, adiposity, and physical activity are associated with cancer risk in this bubble plot. And somebody can log in the website and actually click in each of those bubbles, and more information is provided. And I'm only showing currently the part of the bubble plot that the part of the figure of the interactive figure that shows the inverse associations, but there is another part, there was no space to put it, that shows the positive associations. So the end product of this whole process is the cancer prevention recommendations, and I'm showing you the ones that were published in 2018. There are a set of 10 different recommendations. So be a healthy weight, be physically active, eat a diet rich in whole grains, vegetables, fruits, and beans, limit consumption of fast foods and other processed foods, limit consumption of red and processed meat, limit consumption of sugar-sweetened drinks, limit alcohol, do not use supplements for cancer prevention, for mothers to breastfeed, and also for individuals, for cancer survivors, to follow the cancer prevention recommendations. The reason why we have this kind of recommendation for cancer survivors is that at the time, we didn't have as good evidence for cancer survival, for outcomes after cancer diagnosis, as we did have for cancer incidence. But this is likely to change, and I'm going to say a few more things about that in the future steps. Okay, so during this CAP 2.0 process that started at the end of 2018 and it ended a few months ago, we have decided to build a transition panel and study and think about ways to go forward, both how we can improve the ways we do things in the WCRF AICR CAP, but also areas that we would like to focus on and do systematic literature reviews in the future. So we reviewed all the robust processes by which we conduct our work. And we have already introduced a number of changes in that. For example, we have certain protocols that can prioritize when an association that has been already evaluated before in previous years, when it should be evaluated again based on the availability of data and new studies in the literature, in a semi-automated way. In a way, we have also introduced the concept of rapid reviews. So instead of waiting for a year or more to conduct a fully complete systematic literature review on certain topics that also have a timely component on them, to be able to conduct a more rough but rapid review. We are also introducing risk of bias tools fully into our processes, and we have separate guidelines, new guidelines for narrative synthesis of studies in situations where a meta-analysis cannot be achieved. And we also have a number of different activities trying to automize and improve the early stages of a systematic literature review at our hub at Imperial, so we can gain extra time for later purposes. And we have also a number of other activities or focuses that we're gonna actually work on in the future. So one of them is actually the outcomes after the cancer diagnosis. Some of these areas have been neglected in the past. Most of the reasons why of that was that they had less data to be evaluated compared to cancer instance. But now we are actually studying some of these areas in more detail, and this will actually increase the next couple of years. So at the moment, we are focusing our reviews on outcome on the association of diet and positive physical activity and risk of outcomes after breast cancer diagnosis, colorectal cancer, and prostate cancer. And very soon you will see the initial reports coming out for breast cancer. And within the year 2021, towards the end of 2021, you will see reports also for prostate and colorectal cancer. Another area that's very important that it's neglected is childhood cancers, and especially childhood cancer survivals. So how diet, nutrition, and physical activity affect survival from childhood cancers, and also how the effective treatments, cancer treatments that we have that have improved survival in the last decade or so, how these treatments might affect side effects and also long-term outcomes in those survivors. Another area that's very important and we will focus on is cancer subtypes. There are many different subtypes that we want to look at: anatomic, histopathologic, molecular, genetic, based on risk factors, based on infectious, the infectious component of different cancers. And some of this data is already in the previous CAP reports, but have much less data. And many of those were not meta-analyzed, but this would likely change and has started to change. We have more studies now on cancer subtypes. Another area that we are actually actively working on a systematic literature review is to assess diet and lifestyle patterns, not single dietary components, in relation to cancer risk. And this is a process that will run in 2021. We have a separate protocol to evaluate this type of literature. The same for the life course. So it's very important to understand how diet, nutrition, and physical activity across the whole lifespan are linked to cancer. And we have a separate approach to try to bring together biological data, mechanistic data, and merge them with epidemiological data so that we can use them together to finalize our evidence judgments. And you have a final approach that's a systems approach, a more holistic approach that aims to bring together different multi-level measurements of the different risk factors and of the different environments, and how together all of these affect cancer risk. So a lot of different activities, and you will see a lot of this work in the near future. So before I end, I need to acknowledge the huge work that has been done by the ICL team, the team at Imperial, and which was head by Dr. Teresa Norad until the end of 2019. And from there on, myself and Dr. Dorit Sands are co-PIs of the project. And we have a wonderful and very dedicated list of collaborators and and people in the team. So I have a number of research associates or postdoctoral fellows, Dagfinn, George, and Nerea. Nerea is a new addition in our group, hasn't started yet. Dagfinn is already a faculty in Norway, but he has been still involved in the CAP. And we have another great group of research assistants, Margarita, Katja, and Rita, that are doing the bulk of the most cumbersome part of the systematic literature reviews. And we always have a great collaboration and with the WCRF AICR Secretariat. I'm not naming all the people, but the work couldn't have been done without them. So with that said, thanks so much for your attention. I'm happy to take questions.
Thank you so very much. That was fantastic. I think we're going to hold questions until we get through our next presentation, unless Deirdre tells me otherwise. Otherwise, I'm going to introduce our second speaker, Dr. Melissa Hudson from St. Jude's Children's Hospital. She is the director of the Division of Cancer Survivorship at St. Jude's Children's. She joined the faculty there in 1989. She holds the Charles E. Williams Endowed Chair on Oncology and Cancer Survivorship and is co-lead of the Cancer Control and Survivorship Program at St. Jude's. She's also director of a novel program called After Cancer Completion of Therapy, the ACT Clinic, which is for long-term survivors of cancer, childhood cancer, who've been treated at St. Jude's. Patients move to the ACT Clinic after being cancer-free for 2 years after stopping their therapy and at least 5 years after diagnosis. And the goal of that clinic is to help those survivors to stay healthy. So very much looking forward to your talk. Thank you so much for joining us today, Dr. Hudson.
All right, thank you, Katie, for that introduction. Can everyone see my slides and hear me okay? Just a thumbs up is okay?
Yes, yes.
Okay, very good. Okay, well, I'd like to thank you for the opportunity to highlight the activities of the International Guideline Harmonization Group for Late Effects of Childhood Cancer. Our activities aim to leverage multidisciplinary expertise to improve cancer survivor outcomes. In its similar report From Cancer Patient to Cancer Survivor, the Institute of Medicine recommended that healthcare providers should use systematically developed evidence-based clinical practice guidelines, assessment tools, and screening instruments to identify and manage late effects of cancer and its treatment. And this is particularly important in pediatric oncology because we know that most children, adolescents, and young adults diagnosed with cancer will become long-term survivors. We also know that cancer and its treatment predispose to excess morbidity that increases the risk of early mortality. And there has been abundant late effects research in childhood cancer survivors that provide substantial data to anticipate treatment-related health risks. Importantly, we believe that health screening, surveillance provides opportunities for prevention, early detection, and interventions that may preserve health and ultimately improve quality of life in our survivors. So we feel quite strongly that survivors and providers need guidance to be proactive about cancer-related health risks. Well, evidence is emerging to support that early surveillance provides a mortality benefit for specific highly prevalent late effects, for example, breast cancer after childhood cancer treated with chest radiation in young women. Most late effects, there are challenges in developing follow-up guidelines for pediatric cancers for several reasons summarized on this slide. Survivors of childhood cancer comprise a relatively small population. Currently in the United States, it's estimated to be about 500,000. And furthermore, pediatric cancer is not a homogeneous group. There are heterogeneous subtypes managed with diverse therapeutic strategies and associated with variable health risks. The prevalence of late effects, especially life-threatening events, is relatively low. And this is because pediatric oncologists have modified and risk stratified the use of highly toxic agents and modalities in their therapeutic trials. And finally, delayed onset of the occurrence of late effects precludes implementation of randomized clinical trials that are typically used in the general population and provide that very high quality of evidence demonstrating a mortality benefit associated with surveillance for a late effect. As a result, most pediatric guidelines largely represent a hybrid model that uses the abundant evidence in the extant literature that link a late effect with the therapeutic exposure and allows characterization of high-risk categories. The screening recommendation is typically based on expert clinical experience, matching the magnitude of risk with the intensity of screening. Over the years, most pediatric cooperative groups have developed independently guideline recommendations for long-term follow-up of their survivors, resulting in variations in patient risk groups, diagnostic testing, and screening intervals. This non-integrated approach has resulted in the development of inefficient use of resources, duplication of effort, and uncertainty often about which guideline to follow. Individuals involved in these efforts initiated discussions some years ago that recognized the benefits of collaboration as it would optimize the multidisciplinary expertise involved in guideline development with those subspecialties noted on the left side of the slide. And harmonization was also felt to be an opportunity to reduce duplication of effort, establish standards of survivorship care internationally, and optimally improve quality of survival. And a secondary effect would be identifying a research agenda and enhancing research opportunities. The International Guideline Harmonization Group was then initiated in 2010 by the National Guideline Cooperative Groups in collaboration also with Cochrane Childhood Cancer Group and in partnership with the European Union PanCare SURF-UP Consortium. The goal of IGHG is to establish a common vision and integrated strategy for the surveillance of late effects in childhood, adolescent, and young adult cancer survivors. I co-chair the effort with my colleague, Dr. Leontine Kramer from the Princess Maxima in the Netherlands. The effort has involved over 300 experts in dynamic guideline groups. And we have, in addition, developed a handbook and a methodology paper to facilitate training of new guideline panel members. And all of this is available at the website ighg.org. The IGHG approach to guideline development integrates knowledge drawn from the best available evidence in the literature and clinical experience, and then considers also patients' concerns in the recommendations that are made. Experts are engaged in panels are chosen to assure diversity across countries and healthcare systems, and patient advocates are engaged also to review and offer feedback before finalization of the guideline recommendations. And this slide shows the methods in the harmonization process. First, we determine concordances and discordances of the widely published national guidelines. We formulate clinical questions relevant to the guideline topic. We identify available evidence by systematic literature searches. We summarize and grade the evidence, and we formulate and grade recommendations. Key issues that are addressed for every guideline is who needs surveillance, at what age or time from exposure should surveillance be initiated and potentially terminated, at what frequency should surveillance be performed, what surveillance modality should be used, and what should be done when abnormalities are identified. The IGHG uses evidence-based methods that are adherent to the Institute of Medicine's developing trustworthy guidelines and the appraisal of guidelines for research and evaluation. The level of evidence and strength of the recommendations are evaluated using an adapted version of applying classification of recommendations and level of evidence criteria from the American Heart Association, and also the grading of recommendation assessment, development, and evaluation or grade criteria of the grade working group. The levels of evidence is illustrated in this figure are based on the clinical and scientific expertise following 3 categories. So if you noted in blue on the left, a high level of evidence is evidence that is consistent from well-performed, high-quality studies or systematic reviews. Moderate level of evidence is from studies or systematic reviews with important limitations. And very low level of evidence is from studies with serious flaws or just based on expert opinion. The recommendations, as noted in the color-coded scheme from green to red, are based in categories: green with a strong recommendation based on a high quality of evidence, yellow with a moderate recommendation, orange with a weak recommendation, and red for a recommendation not to do. So this is then translated into the final recommendations that reflects the level of evidence as noted in this slide, such that strong evidence is recommended for specific surveillance Moderate recommendation is reasonable. A weak recommendation may be reasonable, and a recommendation, or not recommended, is when there is no evidence that there's a benefit of surveillance, and in particular, if there's evidence of harms of surveillance. This slide illustrates the diverse late effect surveillance and survivorship topics harmonized to date by IGHG. You'll also note that IGHG is already updating some of the recommendations as noted by the follow-up report on breast cancer surveillance, reflecting the emerging literature and intensity of study on that topic. The IGHG has remained nimble to address rapidly emerging topics, with our most recent efforts involving organization of a COVID-19 working group that developed guidance for childhood, adolescent, and young adult cancer survivors who were at least 1 year after completion of therapy. And the methods for this effort involved a review of local and national health authorities' recommendations for the general population, a systematic review of COVID-19 outcomes with a focus on outcomes such as hospitalization, mechanical ventilation, ICU admission, and death, and translation of these findings into survivorship care. So the next slide shows a screenshot just with the content of the guidance. This was organized through the collaboration of individuals from North America, Europe, Asia, and Oceania. It's available in 11 languages at our website, ighg.org. This was also disseminated through the European Union PanCare, the Society of International Pediatric Oncology, and the American Society of Pediatric Hematology and Oncology, as well as other national cooperative groups and institutions. The guidance focuses on precautions for survivors with health conditions associated with severe course of COVID in the general population, and it addresses interventions for reducing exposure and infection and staying emotionally healthy. And it emphasizes, importantly, the adherence to national and local guidelines, since our effort, our global effort, there is quite a diversity in the approach to these. In addition, the COVID-19 working group distributed a long-term follow-up provider survey that assessed the long-term follow-up care services that were offered, how the pandemic has affected long-term follow-up care, the personal impact of COVID-19 on long-term follow-up providers, and also their anticipated assessment of the impact on future survivorship care. Also within the survey, we assessed novel strategies that have facilitated care during the COVID-19 pandemic. So you can see from the table that we had an excellent response rate of almost 80% that represented clinicians from 37 countries, 5 continents, and 226 pediatric cancer programs. And we have a manuscript that's under development now to describe the results. This slide shows ongoing activities of the IGHG, which contribute to focus on a broad spectrum of medical and psychosocial outcomes relevant to survivorship care. And you can see that we're also updating some of the topics such as cardiomyopathy surveillance. So in summary, I hope I've convinced you that IGHG provides an infrastructure that facilitates global collaboration that will define and update standards of survivorship care as evidence emerges. The IGHG involves a multidisciplinary collaboration, uses an evidence-based approach, and is transparent in deriving and rating the strength of our recommendations. The IGHG activities aim to improve survivorship outcomes by facilitating early detection of late effects and timely initiation of interventions to preserve health and optimize survivor quality of life. And importantly, IGHG efforts have also identified priority research and have generated research and a research agenda and research collaborations to address knowledge gaps in survivorship care. So I thank you for your attention. I leave you with the IGHG website for further information.
Thank you so much, Dr. Hudson. And Dr. Tsilidis, I hope yep, there's your camera. So we do have some questions that have come in for the two of you. And if folks have additional questions, type them in. We have a fancy system behind the scenes so that we know what your questions are, so that I can ask them of our speakers. And I'm taking the chair's prerogative and asking the first question of Dr. Tsilidis. And I actually have 2 questions for you. The first question is, I'm curious to know how the CUP team delineates between lack of evidence versus evidence of lack of effect. So can you speak to that for a minute?
Yes, thanks for the question. So basically, this is very important, and some of the criteria we have are exactly built to be able to delineate between the two. So lack of evidence for us means very few studies, if any, a lot of bias, and between study heterogeneity and evidence of lack of benefit means that we have a lot of studies of good quality, no bias, no heterogeneity, but we have evidence that these studies provide so no association. So yes, we have a system to be able to separate those two. Yeah,
that would seem to be important. So the second question, you alluded to it on your last slide, and I just wanted you to expand on it for just a second. So one of my first mentors as a researcher was Henry Blackburn, who is a cardiovascular epidemiologist at the University of Minnesota. And one of the things he talked about was the three beauties, the triangle of clinical science, bench science, and the population science, epidemiology. And so I'm curious to get you to talk a little bit more about how the Continuous Update Project incorporates intermediate endpoint RCTs, bench science, preclinical work. So how is that either happening or will happen?
Okay, that's another great question. So most of the work we have done during the CAP, during the initial phase of the CAP, was basically collating evidence from epidemiological studies. Mm-hmm. In order to reach a high level of evidence, a convincing grade, we need to have quite a bit of evidence and support also from laboratory studies. We weren't reviewing the laboratory studies ourselves. So this was actually done through the expert panel, or also receiving feedback from our colleagues at IARC, who they do assess mechanisms in their own IARC monograph assessments. So for certain associations that we wanted support from IARC, we were reaching them. And most of the time, they had already assessed the component of the mechanism. However, we are trying to change that going forward in CAP 2.0. So that's why we have a separate system, a separate approach on the biological component. So we are trying to develop, in collaboration with several different universities and researchers, a component of evidence grading that not only takes into account, not only reviews epidemiological studies, but also reviews all the type of evidence, other preclinical evidence, and also RCTs of intermediate endpoints. So this is our goal. This is not easy because it's difficult to be able to judge. And so if you have a lot of evidence from the epi component and no evidence of the mechanistic components, or a lot of evidence from the mechanistic component and no evidence of the epi component, which of the two takes a larger weight? So there was an approach a few years back developed by a grant from WCRF to investigators from Bristol, from the University of Bristol, to be able to develop a framework to bring together in the judgment process both epi and mechanism research. And we are using some of this component, and we tried also to evolve it in order, hopefully within 2021, to suggest ways, at least for certain associations and certain mechanisms, to have a more complete evaluation.
Fantastic, fantastic. I'm delighted to hear it. Okay, so another question after a compliment of great talk. What is the evidence based on stratification by race? Is there enough power for minority populations? Have you done that within the CUP?
Yeah. So wherever we have this data available from the, when we have enough primary studies where we can stratify by race or by country of origin, we do in our systematic reviews. In the majority of the situations, obviously we have the majority of the evidence comes from European descent populations. So majority of our evidence is not specific to other races apart from the European descent population, with some exceptions for certain, for example, salty foods or soy products, that we seem to have more evidence from Asian descent populations than from Europe. Yeah. But this is an area that we are greatly looking forward to have more studies so we can further evaluate in the future.
Okay.
So at the moment, we're not making recommendations specific to any other races, but we hope to do it in the future.
So would this fall into the lack of evidence category of we don't have the evidence to say that there's a difference by race?
Yes, yes,
okay.
Definitely.
Okay, all right. So last question for you is about time frame for the reports on breast, colorectal, and prostate survivors. Do you have any idea when those will be released?
I cannot say for sure because to some extent it's outside of my control because it goes to the WCRF AICR control, but we have completed the report for breast cancer outcomes. So for outcomes after breast cancer diagnosis. So this is completed, and to an extent, I hope I'm allowed to say that, we are actually changing the way we are communicating our results with the public. So it's not going to be a very long report anymore, but it's actually going to focus more on peer-reviewed publications. So within the next months, we will have the publications ready, and we are in contact with these different journals. So I think sometime before the summer, it's the period when the breast cancer information will be communicated. And then this year, during 2021, we are doing the systematic reviews for prostate and colorectal cancer. So I think we will be waiting to see those results towards the end of 2021, most likely.
Okay, thank you. Thank you very much. Dr. Hudson, the last question comes to you. Thank you so much for your talk. And the question is, this is a really excellent talk. The question is, I don't see behavioral topics on your slide. Are physical activity, obesity, and diet within the purview of the IGHG?
You're correct. We don't have behavioral yet. Behavioral issues are addressed within specific topics, for example, in cardiovascular health, most definitely. But I think that this is an area that will be an extension of our work in the near future. The medical and cognitive psychosocial morbidities were prioritized first, and we're leading into eventually going into behavioral outcomes.
Fantastic.
Which are important for
so
our
stay tuned.
Yes.
Okay, great. Thank you so very much. I believe that's the end of our questions. Deirdre, I'm going to pass it back to you.
Thank you so much, Katie, and thank you, Dr. Hudson. Thank you, Dr. Tsilidis, for those wonderful presentations. And thank you to the audience for such great questions, too. It's important that we know what you're curious about. So that concludes the end of this session. And now we have to exit this session